There is something I tell my patients that most doctors never bring up, and it has nothing to do with what is wrong with your brain. It has everything to do with what happens after the test. Here is the truth most people never hear. Sometimes the most dangerous thing is not the condition you are worried about. It is the test you took to look for it. I am Dr. Anika Mehta. I have spent decades in neurology, watching people walk into my clinic feeling fine, a little forgetful, a little foggy, and walk out carrying a diagnosis that was never real. Not because their brain was failing, but because one test led to another, then a specialist, then more imaging, then months of fear. All for something that was never going to hurt them. We call this the Cascade Effect. One test finds something that looks alarming. That finding triggers a referral. The referral triggers another scan. And somewhere in that chain, a person who was living their life starts living in fear of their own mind. Today I want to walk you through 5 memory tests that, after age 60, I would not take. And more importantly, I want to tell you why. Not to keep you away from your doctor, but to help you ask the right questions before you say yes to something that could set that cascade in motion. Stay with me, because the first test I want to talk about is one almost everyone over 60 has already been offered, and almost no one thinks to question. You forgot a name at dinner. You walked into the kitchen and stood there for a moment, not sure why you came in. Your daughter noticed. She got worried. And now someone, a well-meaning doctor, a concerned family member, is suggesting you get a brain MRI just to be safe. I understand that impulse completely. The fear of memory loss is real, and it is deep. But here is what I need you to understand before that scan happens. A brain MRI does not tell you how your brain is working. It tells you how your brain looks. And in a person over 65, those two things are often very different. Think of it this way. Imagine scanning your skin under a high-powered lens. You would see lines, spots, changes in texture. Would any of that surprise you? Of course not. That is what skin looks like after 6 or 7 decades of living. Your brain is the same. It has been working without rest since the day you were born. It carries its own version of those marks. When we scan the brain of a healthy 70-year-old, we almost always find things. White matter changes, mild atrophy, small vessel disease. These terms sound frightening. They sound like something is going wrong. But in the vast majority of adults over 75, these findings are completely normal. They are the wrinkles on the inside. Expected, visible, and not a diagnosis. Here is where it gets dangerous. You receive that report. You read the words cerebral atrophy and white matter lesions. You do not hear a neurologist saying this is what every brain looks like at your age. You hear, something is wrong with my brain. And that fear changes everything. That is where the cascade begins. The radiologist recommends follow-up. Your primary doctor refers you to a specialist. The specialist, to be thorough, orders another scan. Maybe contrast imaging. Maybe additional blood work. Each step adds anxiety. Each report adds a new term that sounds like damage. And by the time you reach the end of that chain, your quality of life has already taken a hit. Not from dementia, but from the fear that the scan created. Research consistently shows that when we image healthy adults over 75, the overwhelming majority have MRI findings that would look alarming on paper. And yet most of those people have perfectly normal memory and daily function. The picture and the reality do not match. I have sat with patients who were sharp, engaged, managing their finances, reading books, staying socially active, and their MRI report looked terrible. I have also seen the reverse. An MRI that looked nearly clean in someone whose function was already declining. The scan does not tell us what we think it tells us. So when does a brain MRI make sense? When the decline is progressive. When someone is getting lost in familiar places. When managing money or daily tasks has become genuinely difficult. Those are red flags that change the equation entirely. That is when imaging earns its place. But for the everyday forgetfulness that comes with normal aging, the missed name, the misplaced keys, the moment of fog, an MRI is far more likely to create a problem than to solve one. Before you agree to that scan, I want you to ask your doctor one question. If we find something, will it change my treatment? If the answer is no, and for mild, age-related forgetfulness, it usually is, then that scan may do more harm than good. Because your brain is not just a picture on a screen, it is a living, working system. And the best way to evaluate it is not to photograph it, it is to watch what it does. Now, the MRI at least requires a doctor's order and a clinical setting. The next test requires neither. It starts in your own home, at your own pace, and the damage it does is quieter, but in some ways harder to undo. You are sitting at your kitchen table. Maybe it is late in the evening. You had a moment earlier that day, a word that would not come, a name that slipped, and now you are on your phone searching. And somewhere in those search results is a quiz. Test your memory now. Could this be early Alzheimer's? Take the 2-minute cognitive screen. So you take it. This is one of the most common things I see in my neurology clinic, and it is one of the most quietly damaging. The problem is not that people want answers. That impulse is completely natural. The problem is that these tools, the online quizzes, the self-administered paper screens, even some of the more official-looking cognitive assessments used without proper clinical context, were never designed to give you a verdict. They were designed to start a conversation with a doctor, not to end one. Here is what most people do not know about the tools these quizzes are based on. Tests like the MMSE, the Mini Mental State Examination, have a documented false positive rate that is significant, particularly in older adults. That means the test can flag a problem where no real problem exists, and the people most likely to receive a false positive are not the ones with the worst cognitive health. They are the ones who are older, who have lower formal education, who have some visual impairment, or who are simply anxious on the day they take the test. That last one matters more than most people realize. Anxiety is not just an emotion. It is a biological variable that directly affects memory performance. Research shows that anxiety alone lowers scores on verbal memory tasks by measurable amounts. A person who is frightened, and let us be honest, anyone taking a memory quiz at home because they are scared is frightened, can fail that test not because their brain is declining, but because their nervous system is activated. Fear is not dementia. But on a cognitive quiz, fear can look exactly like it. And once you see that result, once you read, "Your score suggests possible impairment" on a free online tool, something shifts. The psychological damage is real, and it moves fast. Research shows that nearly 2/3 of older adults who receive a positive cognitive screen result believe they are developing Alzheimer's disease. Not that they might be, that they are. That belief does not stay still. It spreads into how you move through your days. You second-guess yourself at dinner. You stop volunteering for things because you are afraid of embarrassing yourself. You pull back from social activities. You become more isolated. And here is the painful irony. Isolation and withdrawal are among the most reliable drivers of actual cognitive decline. The cascade this time is not a chain of medical procedures. It is internal. The test becomes a self-fulfilling prophecy. This is why context is everything in cognitive assessment. A trained neurologist does not look at a single score. We look at the whole person. Your anxiety level that day, your education history, your sleep, your mood, whether you were grieving something or fighting a cold or had not eaten properly. A number without that context is not a diagnosis. It is noise. So if you have already taken one of these quizzes and the results scared you, I want you to hear this clearly. That result does not define what is happening in your brain. Bring it to a neurologist. Ask for a proper functional assessment, one that accounts for who you are, not just how you performed on one anxious afternoon. The next test on this list is different in a way that matters. It does not come from a search engine or a wellness app. It comes with peer-reviewed research behind it, a specialist's recommendation, and a cost that signals seriousness. And that credibility is exactly why I want you to understand what it cannot tell you. There is a scan being marketed right now as the future of Alzheimer's prevention. It is called an amyloid PET scan. And on the surface, the idea sounds compelling. We can now detect the protein plaques associated with Alzheimer's disease years, sometimes decades, before symptoms appear. Early detection, early action. What could be wrong with that? Quite a lot, actually. And I want to explain why, because this is the test that troubles me most. Here is the biology. Amyloid plaques are abnormal protein deposits that accumulate in the brain and are closely associated with Alzheimer's disease. An amyloid PET scan can detect these plaques with reasonable accuracy. The problem is not what the scan finds. The problem is what the scan cannot tell you about what it finds. A significant portion of cognitively normal older adults, people with no memory complaints, no functional changes, no signs of decline whatsoever, already have amyloid plaques in their brains. Not a small number. A meaningful portion of people over 70 who would pass any memory test you gave them are amyloid positive. And here is the critical point that often gets lost in the marketing. Having plaques does not mean you have Alzheimer's, and it does not mean you will develop it. Think of it like this. Imagine finding a small crack in the foundation of a house that has stood solid for 40 years, shows no structural problems, and is holding up perfectly in every observable way. The crack is real. But does finding it tell you the house is about to fall? No. It tells you the crack exists, nothing more. This is what we call an incidentaloma, a finding that is real, detectable, and completely disconnected from any clear clinical outcome for that individual person. And when that incidentaloma is labeled pre-Alzheimer's, the psychological weight of it is not like finding a kidney cyst. It is existential. It reshapes how a person experiences every moment of forgetfulness for the rest of their life. Every misplaced word becomes evidence. Every tired afternoon becomes a warning sign. There is another problem beyond the psychological. Right now, for most asymptomatic adults, people with no symptoms, no documented decline, there is no proven intervention that a positive amyloid scan unlocks. No treatment your doctor can prescribe that has been shown to prevent the progression from amyloid positivity to clinical Alzheimer's in a person who is currently functioning normally. The information exists, but for most people in that situation, there is no reliable action attached to it. The US Preventive Services Task Force has looked at this carefully. Their position is clear. The evidence is currently insufficient to recommend routine cognitive or amyloid screening in asymptomatic adults. The harms, labeling, anxiety, the cascade of follow-up testing, are real and documented. The benefits, for people without symptoms, remain unproven. Now, there are situations where amyloid PET scanning is genuinely appropriate. In a clinical trial where researchers need biomarker confirmation, in a specialist evaluation of someone with documented progressive cognitive decline, where the result will directly shape treatment decisions. In those contexts, the scan earns its place. That is a very different situation from a healthy 68-year-old who read about the test online and wants peace of mind. Before agreeing to this scan, I want you to ask yourself one honest question. Am I symptomatic, or am I afraid? Fear is valid. I do not dismiss it for a moment. But fear is not a clinical indication for this test. Your brain does not need to be labeled to be protected. It needs to be nourished, challenged, and cared for. And we will talk about what that actually looks like before this video ends. But first, the next test is not a scan at all. It is something your own doctor may hand you in the waiting room, and almost no one questions it. It arrives in a small cardboard box. You spit into a tube, seal it up, drop it in the mail. A few weeks later, you get an email. Your results are ready. Direct-to-consumer genetic testing has made it easier than ever to learn about your DNA. And for many things, that is genuinely useful. But buried inside some of those reports, and increasingly offered through clinical settings without proper preparation, is a piece of information that requires far more care than a notification in your inbox. I am talking about your APOE4 status. APOE4 is the strongest known genetic risk factor for late-onset Alzheimer's disease. Carrying one copy of this variant raises your risk roughly 3 to 4 times above baseline. Carrying 2 copies raises it significantly more. Those numbers are real, and I am not going to soften them. But here is what those numbers do not tell you. They do not tell you whether you will actually develop Alzheimer's. Most people who carry APOE4 never do. The gene is a predisposition, not a destiny. And that distinction between risk and certainty is something a 2-page genetic report delivered without counseling almost never communicates clearly enough. There is another layer of complexity that makes this worse. The predictive value of APOE4 varies significantly depending on your sex and your ancestry. For women of European descent, a single copy carries meaningful increased risk. For men of the same background, the same result carries considerably less weight. For people of African descent, a single APOE4 copy shows barely measurable increased risk. Yet the emotional impact of seeing that result is identical regardless. The test does not adjust its language based on who you are. It hands you a finding and leaves you to interpret it alone. And that is where the real damage happens. Research shows that receiving a high-risk genetic result without adequate counseling leads to chronic anticipatory anxiety. Not the kind of worry that passes after a few days, the kind that settles in, the kind that makes you hyper-vigilant about every moment of forgetfulness, that quietly reshapes your identity, that makes you wonder whether the life you are planning is worth planning. And here is what makes that so medically significant. Chronic anxiety of that kind is itself linked to measurable cognitive decline. The fear of the disease can accelerate the very outcomes the person was trying to prevent. This is the cascade, but it runs entirely inside you. No specialist referral, no imaging chain, just a result, a label, and a nervous system that never fully settles. There are contexts where ApoE4 testing is clinically appropriate. If you are already showing symptoms and a specialist needs genetic information to guide a treatment decision. If you are participating in a clinical trial that requires biomarker profiling. If you have a strong family history and you are working through the implications with a genetic counselor who can sit with you, explain the nuance, and help you build a plan based on what you actually learn. Those are thoughtful, supported situations. That is very different from a mail order kit. Before you open that box, or before you agree to genetic testing in a clinical setting, I want you to ask 2 questions. What will I do differently with this information? And do I have someone qualified to help me process the result, whatever it is? If the answer to either of those is unclear, it is worth waiting. What makes the next test worth examining is precisely where it happens. Not a specialty clinic, not a mail order kit, your doctor's office, a room you already trust, a process that already feels like care. That familiarity is exactly why it deserves a closer look. You are sitting in a cold exam room. You slept poorly last night. You are a little anxious because you have been waiting 40 minutes and your doctor seems rushed. Then someone hands you a brief test. Draw a clock. Remember these 3 words. Count backward from 100 by 7s. The tool itself is not the problem. Tests like the MOCA and the MMSE are legitimate clinical instruments. In the right conditions, they are genuinely useful. The problem is the conditions. Anxiety produces measurable, documented interference on verbal memory tasks. It is not subtle. Research shows that older adults in the top quartile of anxiety symptoms score meaningfully lower on memory tests than those who are calm. Not because their brains are different, but because fear consumes the same cognitive resources the test is trying to measure. The test is not capturing your brain. It is capturing your brain under stress, in a strange room, on a bad day, with no baseline for comparison. And yet, that single score frequently becomes the trigger. A referral gets written. A follow-up scan gets ordered. A label gets attached. The false positive rate for the MMSE in older adults, particularly those with lower formal education or any visual impairment, runs nearly 40% in some studies. Nearly 40%. A good cognitive assessment does not look like this. It is longitudinal. It compares today's performance to a baseline taken months or years ago. It accounts for mood, sleep, medication, and what was happening in your life that week. It is interpreted by someone who knows you, not a snapshot grabbed between other appointments. If you have ever scored low on one of these quick screens, please do not carry that result as a verdict. Ask your doctor, is this being compared to a baseline? Was my anxiety level factored in? Those are not confrontational questions. They are the right ones. And if your doctor cannot answer them or does not have time to, that is important information too. But here is something I want you to stay with, because most people stop exactly here and miss it. Avoiding harmful tests protects you from the cascade, but there is still something that could be quietly working against your brain. Not a test, not a scan. Something most people are already doing, every day, believing it is helping. It has to do with fish oil. Specifically, the way most people over 60 take it. and why that method means it is almost certainly not reaching the brain the way you expect. This is not about whether fish oil works. The research on that is solid. This is about one specific detail of how and when you take it. A detail that determines whether it actually arrives where your brain needs it. Everything you just learned is about clearing the path. This next piece is about making sure what you are putting in actually gets through. The video is on your screen right now. Watch it next.